Hopefully you can see me and hear me. If for some reason the audio goes bad, just let me know. I've got a very finicky computer, even though I know computers aren't supposed to have emotions, but mine do. So today we're going to talk about the extraordinarily exciting topic of update on regulations and guidelines. Kind of kidding there. These are our global learning objectives. And so that means that I'm going to talk about sort of two big areas. One is federal and state regulations that impact prescribing. And certainly there's so many of them, I could never possibly cover them in one talk, let alone a 20-minute talk. But I'm going to focus on the DEA inspection, some recent HHS and SAMHSA announcements, a few words about the state medical board, a few words about the state pharmacy board, and then I'll talk in another area about some clinical guidelines that are related to our practice. And so again, like I said, there's a lot of stuff in here, and many of you already know this, so this is a review, but yeah, we'll just get into it. So you might wonder, you know, why me when it comes to a DEA inspection? And actually, if you've ever been inspected by the DEA, you might want to just put that in the chat box and say a few words about your experience, just so that other people can see what it was like. I've been doing this for 20 years. I've been audited once, and it was probably 15 years ago. And so the DEA is authorized to inspect any ex-waivered physician, and the number of years keeps on changing. It used to be that they would inspect every ex-waivered doctor every 3 years. Now it's up to every 15 years from when you're approved. And the first inspection usually takes place within the first 3 years after you're initially waivered. And mine, like I said, I had already been waivered probably 6 years before they got around to me. So it takes them a very long time to get around to seeing you. So just consider that your inspection is actually a normal part of caring for people if you have an X waiver. The vast majority of us prescribe buprenorphine. There's a small handful of us that actually store it on site and take it out of the safe and give it to patients. If that is you, there are certainly some additional requirements for DEA inspection, such as, you know, how thick in terms of inches of steel is the safe that you keep the medicine in, just as an example. And we're not going to get into that today, but I am always thankful that I don't store and dispense buprenorphine on site. So what you have to do to comply with your inspection is, of course, have a valid X waiver so that they can find you. You have to, it helps if you adhere to the patient prescribing limits. So back in the olden days, if you were waivered for less than a year, you could see no more than 30 patients. If you were waivered for more than a year, you could either see 100 patients or you could jump up to 275. There are a few exceptions that have come up. The first exception that allows you to jump to 100 patients in year one is if you're already board certified in addiction psych or addiction medicine. The second exception to jumping to 100 patients is if you provide buprenorphine in what's called a QPS, or a qualified practice setting. I know you're going to ask me, what's a QPS? So briefly, these are the 5 things that make you a QPS. It sounds like most of our practices. You have to have professional coverage when your office is closed. You have to have access to case management services. Now realize, it doesn't say you have to have case management services. You just have to have access to them. That means you have to have a phone. You have to use an electronic health record. Now that might be the one for some people that they don't have yet. You have to be registered for ORS. Well, of course, we're all registered for ORS because we practice in the state. And probably the most important one, and the reason that they passed this part of the law, is you have to accept third-party payment for costs in providing health services, which means you have to have written procedures about billing and credit and collection. So clearly, to me, they're just trying to cut down on the cash-only clinics here, or the clinics that say, you know, pay me $350 cash, but then, you know, you can use your Medicaid card to pay for the medication. So that is sort of skating on the edge of shadiness, I guess, if you ask me. So, so that's a qualified practice setting. So if all 5 things are true, you can jump right to 100 patients. How you comply with a DEA inspection is that you have to have charts on patients. Imagine that. You also have to have an access to network of behavioral health professionals, and your prescriptions have to be written correctly. Like I said, if you don't come out of medical school knowing how to do these things, I can't help you. So there isn't anything here that's like, how do you write a prescription? Like, make sure you've got the demographic information, make sure you say on the prescription how to take the medicine. I guess what's more important is it has to be dated and signed on the day that you issue it. And with most of us doing e-scripts, that is taking care of us to the exact second that you sent the prescription over to the pharmacy. You also have to include your DEA number and your ex-DEA number on the prescription. This always annoys me, right? Because all of us know, and all of the pharmacists in the world know, that your X number is simply your DEA number. Take the first letter off and put an X, okay? And so I love when the pharmacists call me and they say, Dr. Chris, you forgot to give us your X number. I'm like, okay, first of all, you've known me for 10 years and you've got my X number already, but they make a point of calling me, calling my office, making me call them back, making me, and a lot of times now they say they won't even take my X number off over the phone. So I have to go back into the electronic medical record, redo the prescription, and in the quotes, I have in the notes, I actually have to type in my ex-DEA number or they won't fill it. So again, that's not every pharmacy, but man, some of them are sticklers. So that always cracks me up because I'm like, you know what my ex-DEA number is, Not only have you seen it 100 times, you just take off the first letter and put an X there. Okay. So when the DEA comes to your office, it's going to be one or more inspectors. They have to present their badges to you. They also, Angelina called me. They also have to sign a notice of inspection before proceeding, which includes your physician statement of rights. So it might be a good idea to read that. It's good to notify your staff that the DEA is allowed to conduct an audit so that they don't kind of panic when they see the men in black come up to your door. I'm kidding, they don't wear black. Staff is allowed to oversee the inspection, and so it's good to identify and train a couple people in your office on what to inspect and what to expect from the inspection and how to prepare for one. If you want to have like a little private space in your office for the audit, that makes sense. The audit should be congenial and efficient. That's like right off of the website. So if your agents aren't friendly, I suppose you could complain to the government. These are the things that the DEA is allowed to request. They can look at your DEA registration that says that you have X waiver status. They'll want to see a patient prescription log, a list of your current patients. They want to see what kind of access you have to behavioral health professionals. Not exactly sure how they would figure that out. A copy of your license, a copy of your practice address. So there's advice to keep all this stuff in one place. Make sure you know where it is, your staff knows where it is, update them every so often so that you will be prepared. I don't keep a log. I have figured out a way through the ORS system to generate a log at any moment in time. So if the DEA came back to see me, which I don't know if they ever will, I would go to the ORS page. There's a little blue menu in the top left-hand corner. Click on RX search and then click on My RX and then click on My RX request. Fill in the dates that you want to look at. So I just did this Wednesday of this week. I looked up all the patients I had prescribed controlled substances to over the last year. It was 155 pages long, but that's because if I prescribed, a monthly prescription to a person, then their name would show up 12 times. So you fill in the dates. There's a box for where your X number and your regular DEA number can be checked. Keep both of those things checked. And then there's a place where you can request the name of the drug that you're looking for. I've tried that, doesn't work out very well. So keep that box empty. Then you hit the search button and it'll generate a report which lists every controlled substance that you've written over your chosen time interval. And then what I do is I go to the list where the names are, and I click on it, and it alphabetizes everything. And so then you can download the thing as a PDF. So right now, I just did it for all of 2020. If the DEA comes, I downloaded it as a PDF. It's sitting on my desktop. So when they say, hey, Dr. Chris, let me see a prescription log and a list of all your patients, I'm like, yeah, here's the 155-page report. You can take a look at it. So, so that's how I do it, because I thought about making an Excel spreadsheet, and frankly, that's just a lot of work. And also, I've got a report that the state, the pharmacy board already generates for me, so it's all handy. All right, so what if the DEA comes in and finds a violation? What they can do will be to issue you a letter of admonition outlining the problems, and you've got 30 days to respond. If you do have an inspection and you have any problems, you can contact the National PCS, the Providers Clinical Support System, and that's, again, a national website and resource. So that's a few words about the inspection. So the much more exciting stuff to me is all the stuff that's been in the news lately. And I didn't realize that what happened on January 7th was directly related to what happened on January 14th. So let me tell you the story. So on January 7th, Dr. Eleanor McCants-Katz resigned after the Capitol was stormed. Who is she? She was basically the mental health czar for the United States. She was actually the very first ever Assistant Secretary of Mental Health and Substance Abuse at Health and Human Services. They never actually had the position. They created the position, and she was the first one in it. And she's also the first doctor to ever run SAMHSA, which is, I find ironic and a little bit hard to believe. But basically, after that happened, she basically said, I can't do this anymore. So she resigned. So they put somebody in her place on an interim basis. Apparently, the person that they put in her place greenlit or allowed what happened on January 14th to happen. So what happened on January 14th is that Health and Human Services put out this big, splashy, news announcement that anybody in the country that has anybody in the country that has a DEA doesn't need an X waiver and doesn't need the 8-hour training in order to treat 30 patients. All they need to do is place an X sort of somewhere on their prescription. So they said, we're going to do an exemption, right? And so the exemption was that you can treat no more than 30 patients with buprenorphine for opioid use disorder at any one time, except if you were an ER doctor, in which case there is no cap on that number. You can treat people who are located in the states in which they are authorized to practice medicine. And this only applied to buprenorphine, not methadone. And in order to do it, you had to place an X on the prescription and clearly identify that the prescription was being written for OUD along with keeping a chart, okay, a separate chart. So that's what this piece of paper said. So I got excited. A lot of people around the country got excited, said, wow, this is awesome. So clearly I was in a good dream, and I woke up, because what happened within 9 days is that it is really too good to be true. And so the Washington Post reported that Biden was moving to nix Trump's plan on opioid treatment prescriptions. And so there were 3 officials who spoke on the condition of anonymity that basically said, no, Biden's not going to let this happen. He's going to halt this last-minute plan. And according to an announcement that the Washington Post was able to obtain, it said something like, unfortunately, the practice guidelines had significant legal and clinical concerns, and that the Biden administration would not issue the guidelines that were previously announced. So it's definitely been a roller coaster of 2 weeks as far as this X waiver thing is concerned. And frankly, I'm deeply disappointed that politicians are continuing to play games with people's lives, especially people that have opiate use disorders. And so I'm pretty bummed out about the whole thing. But had not McCants-Katz resigned, sort of always goes back to the storming of the Capitol. So it set off this, series of events, Lemony Snicket, it set off a series of unfortunate events that ended up culminating in this, whole thing. So interestingly, last night, I got an email from the legislative person at ASAM. She was reaching out to all the chapter presidents, and she basically said, hey, ASAM's on top of this, and we're working with the administration to come up with some more reasonable plans, et cetera, et cetera. So who knows? I'm going to keep watching the issue. So, but I shall not hold my breath this time. So let's move on to the State Medical Board. As you know, the State Medical Board has OBOT rules, OBOT standing for Office-Based Opioid Treatment. They had one set of rules in place for about 5 years. Those rules just changed on April 30th of 2019. So we're going on almost 2 years with the new rules. And if you want to find the rules, they're down in red at the bottom. So these rules, interestingly, only cover physicians and physician assistants. If you're a nurse, you have a whole different set of rules, which I can't comment on because I'm not a nurse and I haven't read those rules. But I hear they're similar, but there's some slight differences. But for doctors, it's 4731-33-03. So you can certainly look those up. But I will tell you on one slide what it is in a nutshell. So basically in Ohio, if you have an X waiver, unlike if you work in any other state and have an X waiver, but in our state, you have to prove to the State Medical Board that you've taken 8 hours of CME that's related to substance abuse and addiction every 2 years. So luckily for those of you who are on the ECHO, you can get this requirement done in a month. If you go to the 7 a.m. and the 3 p.m. Every week for 4 weeks, you've got your 8 hours done. If you are a psychiatrist, an addiction psychiatrist, or an addictionologist, you may personally provide behavioral health treatment. If you are not one of those people, then you have to connect with somebody who can personally provide behavioral health treatment for addiction. And the OBOT rules also outline in excruciating detail things that you have to have in the assessment, the labs, the physical exam, the treatment plan, the psychosocial treatment, 12-step meetings, the buprenorphine dosage, urine testing, visit frequency, monobup, and naloxone kits. So that's what's in all of those rules in a nutshell. And again, I'm not telling you anything you don't know. We've been through this many, many times on these calls. What is interesting and what has come up recently is all the stuff with the State Board of Pharmacy. So the State Board of Pharmacy came out and said that you have to have a terminal distributor license if you are an OBOT office, right? And this, I just find it interesting. So not that you actually distribute Suboxone out of your office, but even if you have an office where you write a prescription for Suboxone, you have to have a TDL with an OBOT classification. So it's any location where a prescriber is treating more than 30 individuals. There's 9 exceptions. I'm about to show them to you, so don't worry, don't let your heart rate get up too high. There is like a 75 or 80 page inspection guide that can be accessed on the Board of Pharmacy website. There's the link. And then if you want additional information, you can actually email the pharmacy board by visiting there, and then you can write them a little note and they'll get back to you. I think the guy named Cameron McNamee is still the dude at the State Board of Pharmacy. So he's a buddy of a lot of us on this call. So you can reach out to Cameron if you have questions. I haven't heard that he's left, but maybe some of you guys know different. So here's the 9 exceptions to getting one of these licenses. So again, just try and figure out, read between the lines. Who are they trying to target with this rule, right? So if you're a hospital, operated by a hospital, a physician practice that's controlled in whole or in part by a hospital, if you conduct research, if you're already a methadone clinic, if you have a license or certification from OMAS, if you're an FQHC or an FQHC lookalike, if you're a jail, or if you are, this is brand new as of 12/16/2020, if you are a facility in which patients are treated on site exclusively through the direct administration of drugs that are used for the treatment of opioid dependence or addiction, that are neither dispensed nor personally furnished to patients for off-site self-administration, then this rule does not apply to you. So who does it apply to? for somebody that's kind of like a pill mill and putting up their little shingle and saying, I want to do this, you know, and those are the people that have to get this special thing. So it's, yeah, actually the TDDD OBOT looks almost exactly like the TDDD for a pain clinic. That's what they mirrored the rules on. And so I think what happened with number 9, I can't be sure, but when there was a lot of these freestanding detox units coming up where they were going to be treating people with buprenorphine or giving them naltrexone shots or Sublocade shots, I honestly think that here's my conspiracy theory hat comes on for a moment. I think it had something to do with the manufacturers of Vivitrol, quite frankly. So don't know for sure, but we can talk about it. All right, so that's all the legal stuff. What about the clinical guidelines? So the legal stuff is if you break those laws, you're breaking the law and you're subject to penalties. The clinical stuff is the experts in the field are telling you these are the best practices. And so for me, the 2 best ones that I would refer people to all the time are the ASAM National Practice Guideline and Tip 63. So clearly, many of you, all of you have heard of these things. Just a couple of words of what the updates are. The National Practice Guideline was published in 2015. They did publish a focused update last year. That link right there will take you directly to it. And SAMHSA Tip 63 was originally published in 2018, and I didn't even realize it has already been updated twice. So shows you what I know. So it's always good to teach because then you learn things. So it was updated in 2019 and it was also updated in 2020. How will you know? Because when you click on a link for Tip 63, if you don't see the updated in 2020 emblazoned across the front cover, then you've got the old version. So look for the version that says 2020. So of course I was wondering, so what's in the National Practice Guideline and what's new in Tip 63? So the National Practice Guideline has major revisions to 35 of their existing recommendations, and they've also added 13 new recommendations. Clearly, I'm not going to tell you all those things. I'm sure there's an executive summary somewhere where you can look at that. But I just wanted to give you 3 examples so you would know what kind of changes I'm talking about. One change that was made is that for pregnant women, they sort of declared that either methadone or buprenorphine is the current standard of care, which is interesting because it was methadone for dozens of years. And then they also said that for people with co-occurring opiate use disorder and pain, that it's okay to temporarily increase the dose of methadone or buprenorphine to manage the pain, like acute pain, so a temporary basis, and that you do not need to discontinue methadone or buprenorphine before surgery, that it's not required. Also very interesting. And they also said, only took them 45 years, that individuals that have opiate use disorders within the criminal justice system should, shockingly, receive the same standard of care as individuals treated in the community, which actually I think is huge because basically it means that most of the places where we work are sorely out of compliance. So that means that all existing medications for treating OUD should be available and that patients should be allowed to stay on their medicines. Now, you know as well as I do, whenever you go into county jail or local jail, you've got about a 1% chance of actually getting the buprenorphine that you're already on. Most of the time they'll just stop it and let you go into withdrawal or give you some clonidine and say, oh, well, you can get back on your buprenorphine when you get out of jail. Now, that's changing. Cuyahoga County Metro Health has a pilot project to put people on buprenorphine, Sublocade, Vivitrol. So things are changing, but that's one place out of hundreds and hundreds in Ohio. So what's the summary of what's been going on with Tip 63? Again, the line that I saw on that first page was, quote, to ensure that the content of this tip is as up to date and as useful to readers as possible, SAMHSA in January of 2020 revised certain areas of all 5 parts. It really, guys, wasn't that dramatic, but There are fresh statistics, which is always nice. So if you're using it to teach a class, you've got all the latest statistics there. It basically says that there are additional qualifying practitioners. So CNSs, nurse anesthetists, nurse midwives, so they were added into tip 63. It clarified that extended release injection formulation exists, that's the Sublocade. It added more information about probufene, which are the rods that you stick in your arm, as well as the Sublocade. It added some additional information about med-med interactions. It improved the language about HIV testing and Hep C testing. It also updated the recommendations from the Preventative Services Task Force on performing drug screening in adults in primary care. And then whenever they found a broken hyperlink, they either took it out or fixed it. So that's what they did in a nutshell to tip 63. So I know I have given you way too much information. Here's more references and resources. And here's a fun old Gary Larson Far Side cartoon, which says, "Mr. Osborne, may I be excused, my brain is full." And that's how I felt after I finished making these slides. My brain was so full. So now your brains are full. So I'm happy to take questions, comments, talk politics, etc. No, seriously, I don't want to talk politics. So it's too early in the morning, I'll get a stomach ache. So
does anybody have any questions for Dr. Chris?
Well, no,